Okay.
So,
Good evening, friends, and welcome to the 25th edition of the PG Track program that we have been successfully running in this lockdown period. And today we have a great privilege of having Professor Prabhawati with us. You know, when we talk about the clinical cardiac sciences, one of the common problems that we often see is in the basics of the symptomatology. Often the residents and the fellows are not able to interpret the symptoms properly, and the associated classifications we are not able to answer. How do we correlate those symptoms with hemodynamics, and how do we correlate these symptoms in the clinical case? They are also left unanswered, and this becomes a problem right at the start. So today we requested ma'am to speak on the cardinal symptoms of cardiology, and the first one she would be taking up is chest pain. So along with me, my colleague Dr. Ankit Bansal has joined, and I would request him to introduce ma'am and start the session right away without wasting any time. Over to you, Dr. Ankit.
Thank you very much, sir. Very good evening, ma'am.
Good evening to everybody.
For today's webinar, we have Dr. Professor Prabhawati with us. She is a professor of cardiology at Geneva Institute of Cardiovascular Sciences, and she is a great teacher and a great accommodation. And it is our pleasure to listen about the cardinal symptoms like chest pain and dyspnea from her. It will be a very great session of 1 hour. Please be with us during this wonderful session. Over to you, ma'am.
Thank you, sir. Thanks for the kind introduction. Good evening, everybody.
Share your slides.
Exactly. Is it visible?
Perfect, ma'am. Please make it full screen, and we are through.
At the outset, I would like to thank Dr. Mohit Gupta for giving me this opportunity. Gathering information from patient by history taking and clinical examination is an important clinical skill. In spite of numerous new technologies, which is increasing day by day, these skills still remain crucial for accurate diagnosis. So some of the studies have shown that complete history can establish diagnosis in nearly 80% of the patients. And physical examination and investigation adds only 10% each. In addition, good clinical skills are foundation for successful doctor-patient relationship, which is very important for management of the patients. Today, we discuss one of the cardinal symptoms, that is chest pain. All of you know that commonest symptom of cardiac disease is chest pain. But there are many causes for chest pain, to the extent that cardiac cause contributes only less than 25% in patients attending the outpatient attending with chest pain. Whereas in emergency setup, it can contribute to about 70%. The most important task in the history is to establish whether it's cardiac or non-cardiac, whether it's ischemic or non-ischemic. So cardiac vascular causes are due to myocardial ischemia, most often due to coronary artery disease, which may be stable angina or acute coronary syndrome, or angina can also be seen in myocardial hypertrophy, like in aortic diseases or pulmonary hypertension. Pericarditis, aortic dissection, and pulmonary embolism contribute to acute chest pain. More common causes of chest pain are musculoskeletal, that is chest wall pains like costochondritis, chest wall myalgias, sometimes herpes. Sometimes with the cervical spondylitis and thoracic spine diseases, the pain can radiate to the chest and confuse for angina. Another common cause for chest pain is gastrointestinal. This may be because of esophageal spasm or reflux, sometimes peptic ulcer disease, gallbladder diseases, and pancreatitis can contribute to acute chest pain. Sometimes pulmonary causes like pneumonia with pleural involvement, pneumothorax, and pleurisy can cause acute chest pain. Other common causes for chest pain are psychogenic, and sometimes you cannot make out whether it's cardiac, non-cardiac, anything else. So they are non-specific chest pains where diagnosis is difficult. So this is the list of causes of chest pain. Here we have to differentiate whether it is cardiac or non-cardiac, ischemic or non-ischemic. Common causes of chest pain in the outpatient are chest wall pain and gastrointestinal pain, which contribute to more than 55%, and stable coronary artery disease, only 10%. Remaining are non-specific or other causes. In a study done in the United States, Germany, and Switzerland, here also you can see in the primary care setting, stable angina contributes to hardly 10 to 11% of the patients attending the outpatient with chest pain. Chest pain can be stable, intermittent, or acute. First, we will talk about the stable chest pain, which is intermittent. Here, we have to differentiate typical angina, atypical angina, and non-ischemic chest pain. The main purpose of taking history in these patients is to differentiate between angina and non-ischemic chest pain, which is quite difficult task. Stable effort angina occurs at a predictable level of exercise, and this is due to increased myocardial oxygen demand, called demand angina. So when you evaluate chest pain, we have to start with the location of the chest pain, where it radiates, what is the character, aggravating and relieving factors, what is the duration of the pain, what is the mode of onset, what are the associated symptoms, and sometimes patients' gestures, the body language can tell us whether it's ischemic or non-ischemic. So what is the meaning of angina pectoris? It's a Latin phrase. It means strangling in the chest or choking sensation. It really doesn't mean that it is pain. Many times patients say it's not pain. It is something which cannot be described. Sometimes in the exam they can ask what is Ludwig's angina, because here also the term angina is used. It is again a choking sensation due to severe cellulitis involving the floor of the mouth. So angina is the most common clinical expression of coronary artery disease due to supply demand mismatch. The diagnosis is possible only by history. It is challenged because no single feature is diagnostic, and the quality of the pain described by the patient depends on his intelligence level, education, and cultural background. But still, a good history avoids unnecessary investigations. Here, I would like to share two case scenarios. A 50-year-old male presented with acute chest pain. ECG showed some STT changes. Patient underwent coronary angiogram, which is normal. During the angio, pneumothorax is picked up. If only a proper history was taken, a clinical examination, simple X-ray would have solved the issue. Another example of a 55-year-old male who presented with atypical chest pain for 1 month, underwent coronary angio, which showed borderline LAD lesion, which was stented. He continued to have discomfort with dyspepsia. This time he went to gastroenterologist. Here, carcinoma stomach was picked up. Once again, history would have avoided this unnecessary investigation and treatment. So coming back to angina, angina was described by Heberden in 1772. His masterly description of the angina has not changed over to centuries. So, what are the typical features of an angina? It's a substernal diffuse discomfort, which is deep-seated. Patient cannot localize the pain. If he can localize it is unlikely to be angina. Quality. He often denies that it is not pain, kind of heaviness, burning, as if some stone is kept on the chest, or tightness, sometimes simple uneasiness, or cannot describe. And precipitating factors like physical exertion, motion, exposure to cold, and food. Or if you know that relieving factors are rest and nitrates, with rest or nitrates, pain should subside within minutes, not prolonged for more than 1 to 2 minutes. So duration of the pain is usually between 2 to 5 minutes. If the pain is less than 1 minute, lasting for a few seconds, it's unlikely to be angina. Similarly, if the pain lasts for more than 15 to 20 minutes, it's unlikely to be angina, either acute coronary syndrome or non-angina chest pain. So these are the 5 important features of typical angina: site, quality, precipitating factors, relieving factors, and duration. So this is how you differentiate typical, atypical, and non-angina chest pain. There are other features of typical angina. Radiation. Usually it radiates to shoulders or arms, left more than right. It may radiate to neck or lower jaw, not beyond that. Epigastrium, above the umbilicus, not below that. And sometimes to the back, interscapula area. There may be associated symptoms due to autonomic excess like sweating, anxiety, fear, or palpitation due to sympathetic excess, nausea, vomiting, fatigue kind of symptoms due to parasympathetic excess. Even dyspnea and faintness may accompany typical angina's pain, but it's more often in patients with acute coronary syndrome. So this is the typical radiation of anginal pain, both shoulders, medial aspect of the arm and the forearm, throat, lower jaw. Sometimes patient may go to ENT surgeon with a throat pain or a dentist with a lower jaw pain. Epigastrium above the umbilicus. Sometimes the pain may start with any of these regions. So what is Levine sign? Levine sign is different from Heberden. Very often students mistake Levine and Heberden. Heberden described the angina, whereas Levine described a sign, Samuel Albert Levine. If patient puts one or two clenched fists on his sternal area, this indicates ischemic pain. So this is Levine sign. What is PQRST of eliciting pain information? This is a mnemonic. P for precipitating factors, Q for quality, R for radiation, and relieving factors. S can be site and severity. Time indicates duration. So again, these features are important to assess whether it is typical, atypical, or non-angina chest pain. Anginal pain has a threshold lower in the model. Anginal threshold is lower. They get pain with minimal exertion. As the day passes, anginal threshold improves. And anginal pain is crescendo. It builds up gradually. It will not start suddenly. And once they stop, or with something called nitroglycerin, it gradually subsides. Chest pain lasting for hours and days. Many times we see patients keep on coming with chest pain. It goes on for hours, days, without any evidence of myocardial ischemia or infarction. Goes against angina. So on the other hand, non-cardiac chest pain is localized. Patient can pinpoint and say the pain is in the left inframammary region or any other regions with a finger. The character may be sharp, stabbing, lancinating, or shooting pains or pricking pains. It may come spontaneously or it may be related to the posture, changing posture. or during inspiration it may increase, or by pressure it may aggravate. It's not relieved by rest or sublingual nitrogen. The duration may last for a few seconds or it may go on for hours, and the intensity may fluctuate from time to time. So all these go against angina pain. So this is the table showing difference between angina and non-cardiac chest pain. Esophageal pain is a notorious mimic of cardiac pain. Esophageal spasm reflex. The pain can be indistinguishable from cardiac pain, often mistaken for angina. The common features are substernal, it is squeezing, precipitated by exercise, emotion, and food. And to confuse more, it may radiate to the left arm and relieved by nitrates. But you can still differentiate. It is provoked by swallowing. It may be more common in supine position, maybe nocturnal, and precipitated by stooping forward. Acid reflux into the mouth and relieved by antacids catches the diagnosis. Musculoskeletal pain, which is a second common cause for chest pain, could be aching. The site, intensity, duration, everything varies. And chest pain may change with posture or movement of the upper body. May be able to elicit local tenderness. Finally, psychogenic chest pain, earlier called as Costa syndrome or Neurocirculatory asthenia. This may sometimes mimic angina. This is usually seen in female with other symptoms of anxiety or other psychological disorders. It may be localized, dull, persistent ache, which may last for hours, or sharp stabs lasting for a few seconds. This may usually occur in two situations. If a relative or friend who was recently diagnosed with heart disease or sometimes died of heart disease. Another situation is a patient having a MI. Following MI, they may keep on getting chest pains. Repeated emergency visits with normal ECG, no fresh changes, no troponin elevation. So this is another situation where psychogenic chest pain can be manifested. So angina can be classified into three types. This was classified by Diamond and Forrester in 1949. It was adopted by ACC/AHA in 2002. So it's divided into typical, atypical, and non-anginal chest pain. What is a typical angina? It should meet three characteristics. One, it should be substernal, with a typical quality and duration. Substernal chest discomfort with a quality suggestive of angina and duration of 2 to 5 minutes. So precipitating factors, either exertion or emotional stress, and relieved by rest or nitrates within minutes. So if all three features are there, it suggests typical angina. If only two features are there, it is atypical angina. And non-anginal chest pain will have either one or none of the characteristics. So typical angina will have features of substernal discomfort, quality and duration typical of angina, precipitating factors, and relieving factors. It's very, very important to remember these features because once you say it is typical angina, it has a high predictive value for coronary artery disease, especially in men. This predictive value increases as the age increases. Whereas you can see non-anginal chest pain, the incidence of coronary artery disease is very low. So this is very important to assess whether it is typical angina pain. So presence of risk factors and presence of other vascular disease increases the likelihood of coronary artery disease. For example, a 55-year-old male with diabetes having atypical angina is more likely to have coronary artery disease than a 30-year-old female with a typical angina. So we have to take into account the risk factors and other vascular diseases. Atypical angina may be seen in patients with diabetics due to autonomic system disturbances, elderly patients, and sometimes in females. What is angina equivalent? Here, patients may have symptoms other than angina due to myocardial ischemia. This may be dyspnea, which is due to ischemia-induced airway dysfunction. There may be faintness or extreme fatigue. These things are seen usually in diabetics or elderly people. Sometimes gastrointestinal symptoms like belching, nausea, indigestion, just they may sometimes present with just sweating and sometimes pain at a site other than just like throat or shoulders, arms, or epigast. So, how do we assess the severity of chest pain? Here we have lot of functional classes. The most commonly used is NYHA functional class, that is New York Heart Association functional classification. First proposed in 1928, there were 7 updates, and the 9th one was in 1984. This NYHA functional class has 4 classes, and 4 symptoms included are chest pain, dyspnea, palpitation, and fatigue. So, what is NYHA class 1? Patients with cardiac disease but without resulting limitation of physical activity. That means ordinary physical activity does not cause new fatigue, palpitation, dyspnea, or angina and pain. So here it doesn't tell that beyond ordinary physical activity they develop symptoms. Here note that ordinary physical activity is not defined. And in class 2, patients with again cardiac disease, these are the words used in all the classes. Cardiac disease resulting in slight limitation. Again, note the word slight limitation of physical activity. So they are comfortable at rest. Ordinary physical activity results in fatigue, palpitation, dyspnea, or angina pain. When you go to class 3, it is marked limitation. Again, note the difference, slight and marked. There's a big gap. Marked limitation of physical activity. Again, they are comfortable at rest. Less than ordinary activity causes fatigue, palpitation, dyspnea, or angina pain. Whereas class 4, they will have either symptoms at rest or they cannot carry out any physical activity without discomfort. Class 4 is almost similar in all classifications. So, NYHA class, what are the advantages of this NYHA functional class? As we saw, it is very simple. You can assess very quickly. Anybody can use this. That is, it's most commonly used for functional classification and predict prognosis, including or excluding in clinical trials. It is the most commonly used trial. It's very simple. But the problems are subjective because ordinary physical activity is not defined. And there is poor reproducibility, especially between class 2 and 3. Study by Raphael C. said that there is only 54% concordance among the cardiologists in a patient on the same day. Other limitations are some symptoms like syncopes is not included, PND and orthopnea are not mentioned, but PND is usually included in the class 3 and orthopnea in class 4. So we should remember about NYHA functional class. We should know everything about NYHA functional class because this is again most commonly asked. What is the next one? Canadian classification for angina. Here, this is only for angina. How is it different from NYHA class? One, it is only for angina. Second, there is some objectivity here. See, again, the term used is same, ordinary physical activity, slight limitation, marked limitation, and for the same. So, but here you can see in the class 1, angina occurs with strenuous, rapid, or prolonged exertion at work or recreation. So, even beyond ordinary activity, patient can have symptoms. So, that is class 1. Here, slight limitation of ordinary activities again defined. They can walk more than 2 blocks on a level and climb more than one flight on ordinary stairs at a normal pace. So they can walk beyond 2 blocks. They can walk more than one flight of stairs without symptoms. But angina occurs in walking or climbing stairs rapidly, walking uphill after meals, cold, or under emotional stress, because all these increase the angina threshold. Marked limitation: angina occurs on walking 1 or 2 blocks, less than 2 blocks, or climbing one flight of stairs. So there is some subjective assessment of angina. So how is it different? It's only for angina and it's more objective. What is 1 block? It is the distance between two streets in North America. The distance is usually 100 to 200 meters in most of the cities in USA, and it is about 8 to 16 blocks per mile. One flight of stairs. There is no set criteria. It is this set of stairs between the floors, roughly around 12 steps. There is no standard number of steps. The third is Goldman specific activity scale. This is more specific, and this uses activity in relation to daily life. What is used here? MET, that is metabolic equivalent. 1 MET is the oxygen consumption at rest. It's about 3.5 ml per kg per minute. So multiples of this is used to assess the functional capacity. If a patient can do activities requiring 7 METs or more, it is class 1. Between 5 to 7 METs is class 2. Between 2 to 5 METs is class 3. And less than 2 is class 4. So how do you assess how many METs? You don't have to do treadmill for this. You can know the metabolic needs of each activities. For example, activity of daily living needs about 4 METs. If patient becomes symptomatic during this, it becomes class 2. So this is the most specific functional class and can be used. The next is WHO Functional Assessment Classification for Pulmonary Arterial Hypertension. This is used only in patients with pulmonary hypertension. It is similar to NYHA, but here near syncope replaces palpitation because syncope, exertional syncope, is a common symptom in patients with pulmonary hypertension. You can also use Borg scale and visual analog scale to assess the severity. It starts from no pain to unbearable distress. So patient can point whether it's 4, 5, 6, depending on his perception of pain. 6 minutes walk test is most commonly used in patients with heart failure or pulmonary hypertension to assess the functional capacity. It is simple and reliable. Patient walks in a corridor for 6 minutes. Even in coronary artery disease, it can be used to predict the cardiovascular events. Distance walks during 6 minute walk test can predict the cardiovascular events when you study the Alexis. Now, what are the causes of angina? Apart from coronary artery disease, angina can be there in aortic valve disease, hypertrophic cardiomyopathy, severe systemic hypertension, severe pulmonary hypertension. Here it is more of right ventricular ischemia. Sometimes severe anemia and hypoxia also can present with chest pain exertion. Angina is a frequent symptom in patients with aortic stenosis, as much as about 50%, and it resembles angina and coronary artery disease. It may be due to increased demand, secondary to hypertrophic myocardium, wrong systole, or increased wall stress, or decreased supply due to decreased capital density, decreased coronary perfusion pressure due to increased EDP, and shortened diastole. In elderly people, it may be because of associated coronary artery disease also. In hypertrophic cardiomyopathy, again, half of them can have typical angina. This results in more from impaired myocardial perfusion because these patients have a small ventricle disease, it is intramural coronary artery abnormality, and impaired vasodilator response, blunting the coronary flow reserve. So, again, inadequate capillary density also can contribute to decreased myocardial perfusion. Again, increased demand due to LVH and increased wall stress also contribute to chest pain in patients with hypertrophic cardiomyopathy. These are the commonly asked questions. What is the mechanism of angina in AS? What is the mechanism of angina in hypertrophic cardiomyopathy? So even in patients with AR, angina can be a prominent symptom, especially late in the course. This is because of dilated LV causing increased LV mass and increased demand. But here, more important is nocturnal angina, which can be more bothersome. The mechanism described is during sleep, there is decrease in heart rate. This leads to prolonged diastole and increases aortic regurgitation and decrease in diastolic pressure. This increased AR leads to increase in LV and diastolic pressure. So low diastolic pressure, low aortic diastolic pressure, increase LV and diastolic pressure, decreases the coronary perfusion pressure and results in decreased coronary blood flow. But another mechanism described is diastolic coronary stealing. Because of the venturi effect of the AR jet, there can be reversal of flow from the coronary artery into the aorta. So can patients with MS have typical angina? It is described in 15% of patients with MS. It's because of RV ischemia, secondary to pulmonary hypertension and right ventricular hypertrophy. So this is seen in late stages of MS with severe pulmonary hypertension and right ventricular hypertrophy. Sometimes acute chest pain can be present in patients with MS due to pulmonary embolism. Chest pain in mitral valve prolapse is a common symptom. It's often atypical. Sometimes may be typical of myocardial ischemia due to tension on the papillary muscles. They may have typical STT changes and exercise may be false positive, but normal performance. Chest pain in patients with pulmonary hypertension, again a common symptom. In forward series in Eisenmenger syndrome, it is seen in 15 to 20% of the patients. Again, here it is due to right ventricular ischemia. Rarely, chest pain can be due to compression of the left main coronary artery by dilated hypertensive pulmonary arteries. More rarely, it could be due to pulmonary artery dissection, which is catastrophic. And briefly about acute chest pain. Causes of acute chest pain could be acute coronary syndrome, aortic dissection, acute pericarditis, and other cardiac causes like pulmonary embolism and rarely ruptures and septal. Non-cardiac arrhythmic chest pain also can contribute to acute chest pain. Chest pain due to acute coronary syndrome, everyone is aware, central pressure-like, prolonged chest pain, though it is a weak predictor. Most strong predictors of ACS are pain radiating to both arms, which is a greater predictive value, with positive likelihood ratio as high as 2.3 to 4.7, aggravation with exertion, pain similar to prior presentation, and associated symptoms like nausea, vomiting, diaphoresis have a likelihood ratio of around 2. On the other hand, atypical pains like stabbing, pleuritic, they have a negative likelihood ratio of 0.2 to 0.3. Patient has vascular disease which is established or has coronary risk factors. This increases the likelihood of acute coronary syndrome. Aortic dissection, they have the severe or worst ever pain, which is sudden onset, maximal at the onset. Absence of this diagnosis is less likely. Some studies have shown that tearing pain and migratory pain have high likelihood ratio of 7 to 11. Chest pain is more common in type A than type B, whereas back pain is more common in type B. Rarely they can have classic ischemic pain due to coronary artery involvement, most often right after the action. If the pain radiates to neck, throat, jaw, or face, upper part, it's likely to be ascending aortic involvement. If the pain goes to the back, abdomen, and lower limbs, it's likely to be descending aortic involvement. Acute pericarditis. Here, most of the pericardium is pain insensitive. Pain is most likely to be due to pleural involvement. So it will be pleuritic, increases in coughing, breathing, turning in the bed. But most characteristic feature is it's improved or relieved by sitting and leaning forward. And radiation to trapezius ridge is highly specific. This is because of the phrenic stimulation, which has a nerve distribution similar to the trapezius C3 and C4. Pulmonary embolism, the most common symptom is dyspnea. Rarely they may have central substernal pain due to stretching of the pulmonary arteries. On the other hand, pleuritic pain is more common with pulmonary infarction. Some specific types of angina are commonly asked. Postprandial angina. This follows weeks or immediately after days if you take some physical activity. This can precipitate chest pain. Postprandial angina is a likely marker of severe coronary artery disease, either triple vessel disease or left field disease. It is identified in up to 10% of patients with chronic coronary artery disease. What is the mechanism? It's not fully understood. There are some hypotheses. One, there is redistribution of blood from coronary to splanchnic vascular blood. This is not confirmed in the studies. The second mechanism described is increased myocardial oxygen demand because of increased heart rate and sympathetic activity. The third is redistribution of blood from regions supplied by stenotic coronary arteries to those supplied by less diseased or normal levels. This was confirmed by some studies. Why there is redistribution? In the regions supplied by stenotic coronary arteries, there is impaired vasodilatory reserve. So, there is more blood flowing into the less diseased or normal vessels. This is the most accepted mechanism. What is cold-induced angina? Some patients develop chest pain on exposure to cold. This can occur in about 40% of patients with symptomatic coronary artery disease. Most probable mechanism is peripheral vasoconstriction, which increases blood pressure and leads to increased myocardial oxygen demand. In patients with normal baroreceptor function, increase in blood pressure will decrease the heart rate and will not lead to increased myocardial demand. In patients who are cold intolerant, there is baroreceptor malfunction. So, the increase in BP is associated with increase in heart rate, and this leads to increased myocardial oxygen demand. Another mechanism described is coronary vasospasm. What is warm-up angina or second wind angina, first effort angina? This is described 200 years by Heberod himself. Patient with coronary artery disease walks, gets chest pain, which forces him to stop. He takes rest for a brief period, few minutes, and then he continues to walk. Then there is mild no angina or minimal angina. Why does it happen? There are again so many mechanisms. There may be improvement in oxygen supply because of collateral recruitment or stenosis dilatation or myocardial perfusion redistribution. Or there may be reduction in oxygen consumption due to stunning of the myocardium in ischemic region. But most accepted is ischemic precondition, where myocardial adaptation occurs to ischemia during the first episode of angina. Similarly, there is entity called walk-through angina. Here, patient develops angina during the early course of exertion, but patient continues to walk without taking any rest, and the pain subsides. This again, the mechanisms can be multiple. So during beginning of the exercise, there is reduced blood flow, coronary blood flow because of increase in vascular tone. As patient walks, this improves. So angina comes down. The second mechanism explained is recruitment of collaterals. So nocturnal angina is classically described in severe aortic regurgitation or imprinzment of angina due to coronary vasospasm. Early days, it was commonly seen in syphilitic AR with osteopenia. Nocturnal angina can also be seen in coronary artery disease. This could be due to increased demand. More often, it is supposed to be due to increased demand because it is demonstrated by Holter monitoring that brief bursts of heart rate acceleration was seen before the angina and ST depression. This can occur during REM sleep or during dreams, which stimulates adrenergic surge. And of course, it can be due to vasospasm in the pre-existing lesion. What is angina decubitus? This pain is identical in nature to effort angina, but occurs during night in the recumbent position. It can awaken the patient. The suggested mechanism is there is increased venous return during recumbency. This expands the blood volume and increases the myocardial oxygen demand. This is seen usually in patients with severe coronary artery disease. Variant angina, it's a principal angina or vasospastic angina. Recurrent episodes of chest pain can either occur at rest or during sleep. This usually clusters between midnight and 8 a.m. morning hours. Due to coronary vasospasm, this can occur in the patients with stenotic coronary disease. What is microvascular angina or cardiac syndrome X? Patient will have typical angina and evidence of myocardial ischemia. But now epicardial coronaries will be normal. Here angina tends to be longer lasting with slow resolution. Most commonly seen in patients with peri or postmenopausal periods. This is again described possibly due to impaired coronary flow reserve. Linked angina. This is induced by gastroesophageal reflux. It is not a reflex, it is reflex. Gastrointestinal factors like peptic ulcer disease or esophageal reflux can cause genuine angina in patients with established coronary artery disease. Children et al. Has shown that installation of acid into the esophagus causes typical angina in patients with coronary artery disease. Why does it happen? This is because of reflex coronary vasoconstriction, which is vaguely mediated, called cardioesophageal reflex. So, importance of knowing this is treatment of this reflux can relieve the angina in these patients instead of giving loads and loads of anti-anginal drugs. What is variable threshold angina? Mixed angina. Here, patient has stable coronary artery disease, but sometimes develop coronary vasoconstriction. So that means there is a supply angina. There is a demand angina plus supply angina. So some days are good because they can do more activities without limiting angina, but some days are bad because activity restricted by angina due to vasoconstriction. So this is called variable threshold angina. Finally, what is crescendo angina? Here, patients with stable angina progressively increasing frequency, precipitated in less exertion, may be present at rest or more prolonged duration. So this qualifies for unstable angina. Finally, word about chest pain in children and adolescents. Most reassuring is it's rarely cardiac. Less than 5% of chest pain are cardiac. Most common cause is musculoskeletal, chest wall related, Cardiac causes could be due to, again, aortic obstruction. Acute chest pain can be due to pericarditis or arrhythmias. True coronary insufficiency can occur in Kawasaki disease, Williams syndrome with positive involvement of the coronaries, coronary anomalies. Rarely, there can be premature coronary artery disease due to familial hypercholesterolemia. To conclude, detailed clinical history can differentiate various causes of chest pain. Along with physical examination, it can help us to select proper investigation, thereby avoiding unnecessary investigations with attendant risk and cost. Thank you for patient hearing.
Thank you so much, ma'am, for such a great, simple, and lucid presentation. I've covered almost all the aspects. I was imagining all those fancy terms which are used. And one of the questions that has come up is again, somebody is asking that what is one flight of stairs? And madam rightly mentioned that 12 steps probably is counted as one flight of stairs. And these are typical Canadian blocks, US and Canada. Canada is particularly divided into all the blocks. And that is why this term has originated. Up to 200 meters is approximately one block, and one flight of stairs is 12 steps. Ma'am, another very interesting term that has been used is blockopnea. And some of the people are again fancy and used to using this term. So blockopnea is also one of the equivalents, dyspnea equivalent. Another name for that is blockopnea that was described by Gallagher initially.
I'm not aware.
Oh yeah, so even I was not. So somebody was asking, so we really searched, and this was described by Dr. Chevalier in the Journal of American College of Cardiology. So
Okay,
this
thank
has
you
been
for that.
a fantastic presentation, ma'am, and I think this will give a more. You have taken and dealt with all the deep insight mechanisms related to angina and the commonly asked questions. And another term that they use is status anginosus. So status anginosus, like status epilepticus. Somebody is asking, it's repeated attacks of angina that are occurring after. Every minute. So that is, they say that and not responding to any therapy. They say that this term is used as status anginosus. Dr. Abraham mentioned it in one of the books. Fantastic presentation. Ankit, you have any other questions? So, we have almost 200 plus people who have joined us today, ma'am. And I think such a simple and very easy description of angina is I've never heard. Ankit, you may resonate on that.
Definitely, sir. This is one of the most exhaustive lecture
Exhausted.
on
Angina.
angina I've ever heard.
Heard.
So, what even we can think of any question that has been already been covered in this lecture.
Covered in this
Oh,
lecture.
thank you so much.
There is-
Thank you
Thank
so
you
much.
so much.
There is no scope of questions on this topic.
Questions.
Right?
And I think, ma'am, we are left with dyspnea, I think.
I
Second
thought it
cardinal
would be too
symptoms.
much for
Yeah,
today
so
because
yeah, that's perfect, ma'am. And
yeah.
probably what we will do is that we will have the second session with you on dyspnea, because the mechanisms of dyspnea and the underlying pathophysiology are very, very commonly asked, and most of us and our residents, they get confused on that. So it is great. And my dear friends, all these presentations will be, this lecture will be loaded on the PG Track CSI Delhi branch YouTube channel. I think everyone, right from the clinician, it is not only for the fellows, but the clinicians and the MD residents, whosoever they want to understand the deeper insights into the angina. Probably this is one of the best lectures I've heard from my medical school till this day.
Thank you so much.
Thank you. Thank you so much, ma'am, for joining us today. And we will seek your time for the second session on dyspnea, probably the week after the next one. And this is the way we would be conducting it. And it was great to have you. Thank you, Intas, and all dear friends. If you have any other questions, fellows, please write to us on pgtrackcsi.delhi@gmail.com, and you can listen to all the earlier 24 lectures. If you have any other particular questions or topics related to the clinical cardiology or other aspects of cardiology, please write to us. This is a program for you, and we are encouraging the resident interactions. And in certain sessions, we allow you to join us live on these sessions and participate in the quiz and the different aspects. And we will invite you in the future sessions also. Thank you so much, ma'am, for joining today. Thank you, everyone. And we'll catch up. And let me tell you, my dear friends, that from next week, we'll be switching our PG track program to Thursday evenings. Remember, it will be now on from in Thursday evenings due to some technical reasons, and we will keep you updated about the next program. Thank you for joining.
Thank you.
Thank you.